Hi, everybody. So I'm excited. I was told that I'm the first one who's doing this, so that's pretty cool. Um, I'm gonna be presenting to you some information about gastroesophageal reflux disease, which is abbreviated as GERD, G-E-R-D. We're gonna talk a little bit about I would say the risks of having untreated GERD and the consequences that could at times be dire, and what we can do for everybody to get this situation treated and possibly prevent it from happening. So normally I show slides, and I don't like to go over reading them. Everybody can read the slides themselves, but the summary of this particular slide is simple. It shows that there are quite a few cases of esophageal cancer, that it is on the rise, and mortality from esophageal cancer is quite high, and certainly something that we worry about because esophageal cancer is pretty deadly. Not many people do well with it. So the best thing to do is to prevent it and hopefully even try to catch it before it turns into cancer, like we do with colon polyps. You know, everybody hears of polyps. We take them out so we prevent these polyps from becoming cancers, and hopefully with esophageal disease, there are markers and findings that would tell us there is a higher risk of esophageal cancer developing in some people, and those are the group of people that we try to evaluate, screen, to prevent the development of esophageal cancer, which by the time it does happen is pretty bad. So this is a self-explanatory slide. It shows that esophageal cancer is one of the fastest rising cancers in today's plethora of cancers. You can see the rise is pretty much over 733%. That's pretty scary. And that's been going on for the last 4 decades. So what do we do to prevent esophageal cancers? There are many things we look for. First and foremost, we like to look at who we need to screen for esophageal cancer. And I'm going to show that on the next slide. You can read it and I'll explain it to you. More importantly, we look at people that have esophageal reflux, and we try to evaluate them for the possibility of occurrence of a condition called Barrett's esophagus. Again, in the next slide or two, I will be explaining what Barrett's esophagus is. In a word, Barrett's esophagus is the counterpart of a colon polyp. A colon polyp is a precursor to cancer, and esophageal Barrett's disease is a precursor for esophageal cancer. This is here explaining a type of procedure that we do in the office. It's called EsoGuard. It's a pretty cool device. It's a very simple, straightforward device that we put through the esophagus. It's a balloon. We inflate it. It has tiny rubber, almost tiny shelves or scrapers on it. We pull it through the esophagus. It captures some cells. We send them. These cells are DNA tested for special anomalies that we look for, and if we find those, it indicates Barrett's esophagus, at which time we can categorize these patients and keep an eye on them. So this is the slide that I was alluding to before. This is EsoGuard, and this is the balloon we're talking about. And if you can look at the balloon, it has tiny itty bitty indentations on the sides. It inflates. We pull it through. Cells get caught on these tiny indentations. They're soft. Don't worry, they don't scratch, and you don't feel it. They come out, and then we send this balloon. They scrape the cells off. They magnify them. They look for certain DNA anomalies, as I told you. Now, who do we screen? And that's the more important part. If you look on this slide too, and I'll give you time to look at the blue color writing, so even though it says male, I see it plenty of times in females, but this is the highest risk group. So male sex, older than 50, even though I've seen it in many young people. Truly, to be fair, you want to look for people that have had esophageal reflux disease for more than 10 to 12 years. However, this here can address anybody irrespective of the presence of symptoms of reflux. The reason I say that is simple. A lot of people have severe esophageal reflux, and yet they do not have the symptoms of esophageal reflux as we typically talk about it. So 25% or so do not even know they have bad acid reflux disease. So we go back to this category of people that don't have many symptoms, and they don't volunteer by coming to the doctor's office saying, I have terrible acid reflux disease. Because those, when they come in and they say, I have terrible reflux disease, they already admitting to the reflux, and those are the ones that we go and scope and evaluate and treat. Now, this category I'm discussing on this slide are people that just walk into the office. For example, they walk into a doctor's office, an internist, their primary care physician, my office, because they're walking in to say, I want a colonoscopy. So we look for this category of people: male, older than 50 years of age, smoking, as everything else in life, every cancer in the human body, you smoke, you're a higher risk for types of cancers, period. Obesity, and patients with family history. BE stands for Barrett's esophagus. Family history for Barrett's esophagus, or EAC stands for esophageal adenocarcinoma. So if a person walks into your office, they're older than 50, and they had a family member that developed in their lifetime esophageal adenocarcinoma and or have history of Barrett's esophagus, those are the higher risk patients. Those patients are prime for us to do an EsoGuard at the office. You put that tube, you take some cells, you send them off. If it's negative, the negative predictive value is almost 100%. Not 100%, but very close. And that's amazing, because if it's negative, then you're done. You don't have to do an endoscopy or anything else. But if it shows anomalies, then you have to put them in a high-risk group, do an endoscopy, possibly do more biopsies, keep an eye on them. The reason you want to do an endoscopy is to know the length of your Barrett's esophagus. I don't want to go into the details and the boring medical stuff, but the more Barrett's esophagus, the more the risk of esophageal cancer. Goes without saying. So now the EsoGuard tells me there is Barrett's. It's not going to tell me that the Barrett's is 2 centimeters, 3, 4, 5, 6 centimeters. It doesn't say that. So now I want to know how many centimeters of Barrett's are involved in the esophagus, because the higher that number, the higher the risk. And plus, when you have a lot of Barrett's esophagus, now we have treatment options that I can offer to patients with Barrett's esophagus. Namely, it's a type of treatment called the halo. What we do is we put in a special radiofrequency ablation device and we burn the Barrett's. But we're not here to discuss that. We're here to talk about the higher risk of esophageal cancer and what we do to prevent it. So, it's clinically recommended to test these people. This is the same slide as before. It just goes into the details of saying who and why, and that it is basically recommended by the American Gastrointestinal Association and American College of Gastroenterology that we need to evaluate these people. I've been practicing this forever and ever. Basically, when I have a patient comes into my office for any reason whatsoever, even IBS, for example, or because they need to have a colonoscopy, the first thing that I ask them after we set up the colonoscopy, do you have any symptoms of acid reflux? If the answer is yes, how often? Do you take medicine for it? How long have you had the acid reflux disease for? And now I am narrowing that patient's risk into a more manageable category and what I need to do about it. And when any of these responses by the patient are what we call a red flag, meaning what you see in front of you, male, over 50, white person, smoking, obesity, etc., or frequent acid reflux or nocturnal, that's the bad part. They wake up in the middle of the night with severe acid reflux. And I'm not talking about once in a blue moon you wake up with acid reflux. Every so often we eat late at night, we don't pay attention, we're tired, we go to sleep. That happens. I'm talking about the repeat offenders, people that get it all the time. Those are the people you want to scope. Now you're telling me, or you might ask me, so the patient is not white, so what do you do? Well, then I go by symptoms and I need to scope them because I need to scope them, meaning they're having trouble swallowing, or they have severe acid reflux not responding to treatment, or they have very severe acid reflux and they're not on treatment. So those categories, I scope them because they need to be scoped. You might even ask me, well, have you seen Barrett's esophagus in people of other races, namely people of African American descent or South Americans or Orientals? The answer is I do see it every so often, but it's interesting because we know that ethnicity affects the genetics, and those people do not have a very high risk of developing esophageal adenocarcinoma. Again, we go back to Caucasians. And I give the example to sickle cell. You know, people of African descent have sickle cell disease. Whites don't have sickle cell disease. So when a white person walks into my office with a blood problem, I don't go checking into sickle cell disease. Same thing applies here. So you gotta know your stuff, and you gotta go and orient your search depending on what the studies show and what you expect to be going on. So this is a very interesting slide, very interesting slide. You notice how many people have chronic GERD, 46 million, right? And then you go that of those 50 years or older, 34 million. Then you go down the line and you keep going down, and you notice only less than 1 million of them end up undergoing an upper endoscopy screen. So we need to pick up that number, like we did with colonoscopies. When we first started colonoscopies, we didn't do them that many. And then the numbers kept going higher and higher and higher. People getting educated, we're promoting it. Now we're catching more colon polyps. We are reducing the risk of colon cancer, and that's what we need to do with esophageal adenocarcinoma. We need to capture those high-risk patients to prevent the esophageal cancer, because truly and honestly, if we catch a patient with esophageal adenocarcinoma, anything above stage 2B, their risk of mortality is extremely high, extremely high. It's got to be stage 1, possibly 2A, to consider that it's a life-saving procedure. Otherwise, it's a very deadly cancer. As opposed to colon cancer, if you catch it in stage 1, 2A, 2B, even 3A and 3B, you still have a much higher survival possibility with colon cancer compared to esophageal cancer. So this is a very nice slide. I like it, actually. So here are what we talk about. You hear me say esophageal Barrett's disease or Barrett's esophagus or any of those, right? And then this is what this means, right? So this is the heartburn, the commonly described heartburn, right? Not every esophageal reflux is a heartburn, and not every heartburn is esophageal reflux. But we're not going to go into that discussion. So patient comes in and says he feels a burning sensation, or food is coming back up. That's considered to be heartburn. Now, if you move to the next slide, now you see that there are that pink, we call it the salmon pink mucosa, where the color of the lining of the esophagus, which is normally pearly white, which you see it in this slide, is starting to turn pink. Pink is the color of the liner of the stomach and the small bowel. The lining of the esophagus is the same as the lining of your skin. It's called squamous cell, and that is pearly white. When you see the creeping pink color into the esophagus, and it's what we call the salmon pink color, we're thinking Barrett's esophagus. We go ahead and biopsy it. Now, Barrett's esophagus, like polyps, they go through stages, right? So the more advanced the stage of dysplasia we call it, which displeased, right? Dysplasia, the higher the risk of a transformation into cancer. So you have mild, moderate, severe, you have indeterminate, all these fancy words. In any case, when you have dysplasia, that's a precursor to esophageal cancer. The very last stage, as you see on the last slide, on this side, it's the esophageal cancer itself. The problem with the esophagus, it's missing one of the lining or the wall liners of the esophagus. So when cancer or tumor penetrates, it passes through very fast, it spreads into the lymph nodes, and the rest is history. We don't like that. We want to catch it before it turns, and if ever it starts turning, you want to catch it in the dysplasia stage or very early stage 1 stage. You hope not to get to stage 1, but again, dysplasia is the most you want to catch it at. It's a bad cancer. Let's leave it at that. We want to catch it early. We want to treat it. So this talks about the clinical need for doing things. Again, it's not that important because we discussed it all along. What we need to do is capture more people. That's the take-home message. The more people we catch in the early stages of Barrett's esophagus and we keep an eye on them, the more likely we are to catch them before they turn into adenocarcinoma. Sadly, just last week alone, in my own practice, while I'm doing my endoscopies, I diagnosed 2 patients with esophageal adenocarcinoma. One of them didn't have a single symptom of esophageal disease, none. The other one had symptoms of trouble swallowing. Both patients turned out to have esophageal adenocarcinoma. We don't want that. We don't want to see it. It's a terrible disease to have. So, what are some of the symptoms of esophageal reflux disease? GERD. So, hoarseness or voice changes. Now, I say those are some of the symptoms. There are many what we call extraesophageal symptoms. There are many patients that present to you with asthma-like symptoms. But these are some of the simple things that patients may complain of. Hoarseness, hiccups, excessive belching, especially after a meal, sometimes difficulty swallowing. That's a very terrible sign. We don't want to hear it. But if we do, it could be scar tissue, which is the most likely diagnosis. Those are the ones what we call red flags. I go in, I scope, I fix. Sore throat is not uncommon. Heartburn is the most common. Chest discomfort, not related to cardiac disease. Regurgitation, which means they tell you food is just backing up into my esophagus. Sometimes I wake up in the middle of the night and I feel I'm choking on food in my throat. Coughing, choking, sneezing. Nausea after eating is not a very strong symptom. It could indicate all kinds of things. Diabetics get it all the time because of gastroparesis. So it is a weaker symptom, but it's nonetheless a possible symptom. Sour taste in the mouth. Some people complain of bitter taste in the mouth. But a lot of my patients, believe it or not, are sent to me by the dentist because they go to the dentist as they're examining their teeth. They go, your teeth are rotting on the backside. I think you have bad acid reflux. You need to go see a gastroenterologist. And yeah, I do get a lot of patients referred by dentists because they are suspecting bad esophageal disease or reflux disease. So at the risk, we go again, and I like to repeat things again and again because you know, it enforces the fact that this is the group of people we need to look for. So this here describes how EsoGuard works. It's a pretty cool test. We do it in the office. You don't need to be sedated. You don't need to come to the hospital. You don't need any of that stuff that we do for an endoscopy. It's not a true endoscopy. All it is a sampling technique to get some cells to be sent for a DNA test. I'm not going to go into the details. You're not interested in that. The bottom line is it works. And it tells me if you have Barrett's. And as I said, if it does tell me you have Barrett's, I move from that point on to evaluating the extent of Barrett's and put you on a watch list. So we keep you under surveillance and we make sure that we keep an eye on your Barrett's esophagus. It's showing here the size of the capsule. You basically swallow it, you inflate it, you pull it back, you're done. My staff have become quite the expert at it. So they do a pretty good job. We had few cases last Friday when I was in the clinic and they did amazing. All right, so now it's time for you to ask me questions. I went through this relatively quickly, but I do want you to know that I'm available for any questions you have, and we can discuss him and explain what needs to be explained. So Kim asked, is there treatment for Barrett's esophagus? And as you recall, Kim, in my conversation at the beginning, I said we offer treatment for Barrett's esophagus, and the answer is yes, we do have treatment. There are many modalities to treat, so many different ways of doing it. But the one we have at our hospital uses radio frequency ablation. It's called Halo. We have several different designs. There is the Halo that is a balloon that extends and burns 2 centimeters circumferential at a time. We have other devices that we attach to the tip of the scope, and they burn anywhere from 60 to 70 millimeters. And there is one that goes through the scope and burns small spots. And it's called Halo. Basically, as I said, radio frequency ablation. It penetrates 0.2 millimeters, and we burn a couple of times, and it kills the Barrett's esophagus. By killing the Barrett's esophagus and the superficial layer of cells that are the Barrett's esophagus, squamous cells, which, as everybody should recall, I mentioned squamous cells is the natural liner of the esophagus. So squamous cells come back and populate the areas that were invaded by the Barrett's esophagus. Now that we eliminated the Barrett's, the normal cells will go and recover that area. And now we don't have Barrett's, we have normal cells that belong where they should have been in the first place. What's the youngest age you could have these issues? Good question. In my experience, the youngest person I've ever seen with Barrett's esophagus was a 19-year-old. It's mind-boggling how that is possible, but that particular person basically had acid reflux disease from birth. And yes, it can be that young. But on average, it's much older people, not much older, but you know, I've seen it in the 30s, 40s, and 50s, but that's why we look at 50 plus. Now, the other question that might be asking itself, and I'm sure somebody might have thought about it, when do we stop screening? When do we stop doing any test? And when do we say, well, the patient hasn't had esophageal cancer by this time, I don't think they ever will. So that is a little debatable, but for women, we say 68 to 72, depending on the patient's well-being and their clinical situation. For men, it's 74 to 78, again, depending on the clinical. Now, if the patient is 65 and has multiple medical problems, cardiac disease, this and that, and had multiple endoscopies, and there is nothing in the esophagus, we can stop at that point, because you don't want to have the high risk of doing endoscopy on a patient that has other medical issues to deal with, right? So the youngest person I know of in my practice that had esophageal adenocarcinoma and ended up passing from it was a 27-year-old. It's a terrible thing to have. That's how bad it is. Okay, so is it painful? Absolutely not. It's not painful. Is it uncomfortable? A little bit. So I don't know if you notice in one of the slides, it says even people with terrible gag reflex, 98% success rate. So basically, it is a very flexible, soft, mushy tube with the bulb at the end the size of a small, tiny tablet or pill. Basically, the patient swallows it, and it's like swallowing a pill, really. It's uncomfortable because that pill, instead of going to the stomach and staying in the stomach, is attached to the tube. Once this pill slash balloon is swallowed, you inject air in it, it inflates, and then you pull it back. Really, that's all there is to it. We do not spray the esophagus with a numbing medicine because you want them to be able to swallow and you don't want them to choke on their saliva. So it's literally like taking a pill. No, that's Katie, that's what I said. We do not use numbing spray because you want them to feel the swallow. Like it's like asking me, do I use a numbing spray before I take a large pill? The answer is, of course not. No, you just gotta be able to swallow it. You see, you take a sip of water, you swallow it, it's down in your esophagus and down to the stomach. Once it hits the stomach, we have a marker, we put the balloon, air in the balloon, and we pull it back. That's an excellent question. First and foremost, male, more than 10 years of esophageal reflux disease, basically, if you've never been scoped, I would say at least once in your lifetime, you either need a scope or an EsoGuard. Good question. Normally, if you had Barrett's esophagus and you had it successfully treated, we do keep you under a observation and surveillance with the endoscope. So usually it's still recommended every 3 years or so to have an EGD with biopsies, because the EsoGuard might miss it, because sometimes the Barrett's is hiding under the squamous cells, so we do take random biopsies. All right, the EGD is way different than EsoGuard. EsoGuard is basically like taking samples of a cell. There is no visualization. You don't know anything from anything. You put that capsule, you pull it out, cells stick to it, you send it for DNA test. The EGD, which stands for esophageal gastroduodenoscopy, is totally different. You're taking a scope, you're visually looking, inspecting the oropharynx, the esophagus. If there is Barrett's, you physically see it. We have different types of technology, for example, called NBI, narrowband imaging, that puts, for example, Barrett's in the in a field of vision that is very good for us to identify it. It even identifies anomalies within the Barrett's esophagus, that NBI technology. We can do oriented biopsies, meaning the EsoGuard is doing a blind sampling of cells. With the scope, I can take biopsies, and I can direct my biopsies into areas I suspect are abnormal. So totally different. Plus, if there is tumors, I see it. If there is a stricture, I see it. If there is a stricture, I dilate it. Then I go to the stomach, sample the stomach, look at the stomach. I go to the duodenum, sample and look. So basically, it's a video process of evaluating everything and doing directed, oriented biopsies, and even brushings. I can even brush it. There is something we call Watts, which is a brush that we take and we put it through the Barrett's and brush several areas to get multiple samples. So the EGD is way more involved. You have to be sedated, but it is definitely a totally different technique. And if you do have a positive EsoGuard, then I still want to do an EGD, as I said before, to know the extent of your Barrett's esophagus. Let me tell you what EsoGuard is. If you ever heard of a procedure called Cologuard, you send stool samples and they look for DNA anomalies and they say, oh, it's positive. Uh-oh. So now we have a positive test from the stool telling me there is a possibility of something being wrong in the colon. What do I do next? A colonoscopy. So basically, it's a screening test to screen those that might have Barrett's from those that don't. And that's the beauty of EsoGuard, is that it has a negative predictive value that is very high. Meaning, if it's negative, it's truly negative. But if it's positive, then I gotta go and evaluate that positive. It's like doing a hemoccult test. You take sample of the stool, there is a little blood in it. That doesn't tell you anything. Could be coming from the mouth, it could be coming from the small bowel, from the colon, from a hemorrhoid. But what it does tell you, there is a possibility that could be coming from a polyp. Now you need to do a colonoscopy. Same principle. EsoGuard is positive. It's telling me there might be something abnormal. I need to look further into it, and that's where we go, do the endoscopy, and basically evaluate it way more accurately and what's going on there. Makes sense, I hope. I mean, theoretically, you don't have to be MPO, but in case you want to gag or something, you don't want to throw up, it's nasty. So you might want to come, I mean, if you want to have a coffee, you can have a coffee. But how long does it take? It takes like a minute and a half or two. It doesn't take long at all. It's just like swallowing a pill, putting it inside, pulling it back. Excellent question. I don't know what insurances do or don't do, but if we decide to do an endoscopy, you can be assured it's very unlikely they'll deny you, because there is a reason for us to do it. Now, on the other hand, if they have very strict criteria, and insurance, as I said, decide what they want to decide, because at the end of the day, they're in the business of making money, not in making you feel better. Basically, if you have a positive EsoGuard, they cannot deny it, because you have proof that you have Barrett's esophagus and you do need to be scoped. Then you do an endoscopy. But that's very good. Yeah, some people say, I can't swallow. And as I said in the description before, most people were able to do it without any problems. But if you cannot swallow a pill, that's not the only test. That's a cool test that we have introduced recently. But at the end of the day, the gold standard is an upper endoscopy. We'll still go and do an upper endoscopy. Absolutely. People that have had gastric sleeve have a very, very, very high risk of esophageal reflux disease. And a lot of patients ask me why. And that's very interesting, by the way. So you're taking a stomach that can accommodate at least a pound or 2 or 3 of food without any problems and turning it into a tube that can barely fit 2 to 4 ounces of food, right? So now you eat, it goes into your stomach, there isn't much space, and then food's gotta sit there, and still the stomach has the intact pylorus, the intact everything, and the food is sitting there now, it's causing acid, and there is more things in the stomach that need to go somewhere. But the pylorus is not releasing it because it's not supposed to release it for half an hour or so. It's gotta go somewhere. Where would it go? The path of least resistance. Where is that? Up in the esophagus. People with gastric sleeve have a much higher risk of reflux than any other category. So yes, especially if they had the sleeve for a while. This is the number to call if you're interested in scheduling a EsoGuard procedure. And of course, anybody that comes to our practice as a patient to our gastroenterology clinic and they have acid reflux or they meet the criteria we've been discussing on this presentation, we obviously gonna offer you the EsoGuard and explain to you what it is, how it's done, etc., etc. And on the other hand, if you decide to do it and you feel like this is something you want to have done, this is the number to call. All right, I guess that's it for all of us. I hope you guys enjoyed it. I sure did. That's pretty cool. Yeah, let me know if you need anything.